Hi, Dr. Cavalcanti. It's a great thing to have you here in Chile. So, I would like to ask you, what would you consider the major milestones in the development of reconstructive urology in the world as well as in Latin America?
Thank you for the invitation to be here. It's a pleasure to be here in Chile with the Chilean Society of Urology. So I started doing uretroplasty in 1998, just when I finished my residence training. And at that time, the majority of urologists performed dilatation and endoscopic procedure to treat all types of urethral stricture. And just a small number of centers performed uretroplasty as the first choice for the management of urethral stricture. So after that, we could see the development of uretroplasty, and then the uretroplasty become like the first line of the treatment of sternal urethral stricture when we observed that the results of the endoscopic treatment was not so good. Then a big mark on the uretroplasty was the development of the grafts, buccal mucosa grafts. First, we used just anastomotic uretroplast and for some case, flaps, skin flaps. Very nice surgery, very beautiful surgery, very nice to make very nice videos, but with sometimes worse results. Just only diverticulum formation, infection, all the problems. With the grafts, we could treat with the grafts, and with the time using grafts, we learned with Dr. McAnish with the ventral graft, then Dr. Barbagri with the dorsal graft, then Dr. Kulkarni with the dorsal graft with one side approach, and with Dr. Kulkarni, the use of the graft for the penile urethra. For me, it's a revolution on the management of the urethral stricture. After that, we start with another milestone, in my opinion. That is the concept of tissue preserving surgery, vascular preservation. Now we know that if you cut the urethra to do anastomosis, you can have problems to the patients, erectile dysfunction, change on the gland sensitivity, cold glands. So we are now thinking to how to preserve. Then we start think that retroplasty was excellent for everything, but we're not looking on other points like sexual function and cosmetic issues. After that, we start to look in the old concept of endoscopic procedures with the paclitaxel, with the new balloons to open the urethra and to leave there an antifibrotic agent. That's for me a revolution. We are now adding technology to the uretroplasty with the balloons, with the robotic surgery, with the endoscopic uretroplasty. That's something to the future. We are also looking and waiting because remember that I told you that I started uretroplasty in 1998, and in 1999, Anthony Atala did published the first study with this matrix, with the regenerative medicine, with the tissue engineer, and we still don't have good clinical papers on that. That's why I hope that we are improving now in regenerative medicine, and paclitaxel is a type of regenerative medicine because we are looking for antifibrotic procedures that can at least help our traditional uretroplasty procedures. So we have a lot to develop to increase in the future, and I believe that reconstruct the learning curve of uretroplasty and the learning curve of reconstructive urology never stop. And if you talk to Latin America, we are talking about regenerative medicine, but for Latin America, we still have we need to train. We need to create new centers. We need to create people that can give your experience to others that want to learn about reconstructive. And the Chile is very important for that, because here in Chile you have many people, many centers as you, as Laura, as Reinaldo Gomes, and the others that are very open to teach. And that is what we need in Latin America.
Well, Dr. Cavalcanti, it was a true pleasure to have you here. I think this will be the start of a closer friendship between our people and centers. And well, it's been a very beautiful experience to know you.